Okay, this video is when to give IV contrast for a spine MRI. This could be cervical spine, thoracic spine, or lumbar spine. Most commonly imaged part of the spine is the lumbar spine because a lot of people have low back pain. Next to that would be cervical spine. A lot of people have neck pain. Not that many people get a thoracic spine MRI because pain in that area is less common. But, we still get some of those. Okay, so the vast majority of patients, say about 80% of patients, do not need IV. Most of the time, it's for workup of chronic back pain. You can also hear it called lumbar radiculopathy. Radiculal means like radical, like the root going down into the leg, okay, when it's a lumbar radiculopathy. Lumbar is your lower back. Okay, if it's in the neck, then it would be a cervical radiculopathy, and that would mean to go out into your arm, the pain, the discomfort, the numbness. Myelopathy would mean concern about compression of the cord, which can cause difficulty walking, for example. Okay, so anyways, that's the vast majority of patients, about 80% of patients, back pain. What does contrast do? It shows you where there's abnormal uptake. It can be a breakdown of the blood-brain barrier, the blood-spinal cord barrier for the central nervous system. The brain and the spinal cord are the central nervous system. Also, just damage to the tissue with abnormal inflammation, and that would be anywhere there's an infection, for example, or most tumors. Again, neurologists are usually going to want IV contrast, and it's for the simple reason that this is what they'll tell you. I've had this conversation with them many times. Our patients are mostly old. They don't travel easily. A lot of times they had to put a lot of effort into getting a family member freed up from work that can go with them to the meeting. So they want to be able to have definitive imaging, including IV contrast, done before the visit so they can make a coherent treatment plan, okay, and discuss it with the patient and the family. All right. The next thing, though, is for somebody who's young, walker, talker, with it, knows what's going on, given a choice, I prefer not to get IV contrast, even though it's given numerous times every day and it's pretty safe. If I could avoid it, I would avoid it. Okay. I could always come back and get a follow-up IV if I needed to. Okay, that's my personal attitude. But most patients are not like that. Most patients are old, debilitated, kind of clueless, and they want to get it done in one time. They don't want to come back. Okay, and I don't know if that might lead to more cost. It probably will. Okay, when do you need to give IV? If you're looking for a primary spinal cord tumor, that's super rare. I hardly ever see primary spinal cord tumors. What do I see? Maybe 1 or 2 a year, if that much. 1 a year, probably. A de novo tumor. So yes, they occur, but they're really, really rare. What else? Infection is super common. Infection is something you'll deal with every day. The typical patients who get spine infections are usually older and debilitated because their spine is partially devascularized from all their atherosclerosis, they're immunocompromised from their diabetes, from being elderly, from being decrepit, from having chronic kidney failure. If the patients had previous surgery in the lumbar spine, IV contrast can be helpful to differentiate recurrent disc herniation versus scar formation in the central spinal canal. Drop metastases from brain mets or some other brain tumor, it can happen, but that's really rare. Possible dural AV fistula or AVM, arteriovenous malformation, super rare, but you can give IV contrast to look for that. Meningioma, other extramedullary spine tumor, meaning a tumor outside the cord, they're really rare, but IV helps to show them. All this stuff is super rare. Back pain is ubiquitous, every day, all day long. This other stuff's rare. Okay, when is IV usually given but not necessarily required? And I would say with metastases. Now, metastases to the spine are totally different than metastases to the brain. Brain parenchyma, you absolutely have to give IV to see it. But with the spine, you're usually talking about bone mets, metastases to the vertebra, and it's usually going to be the vertebral body. And in that setting, you don't need IV. I can tell if there's a met almost always with no IV. Okay, now why does oncology usually like to give IV? And the reason is it can be helpful sometimes. Sometimes you're concerned about the tumor extending from the vertebra, the bone, into the soft tissues of the central spinal canal. And IV shows that a little bit better. IV also shows a little bit better if you've got tumor extending from the vertebrae into the neural foramen. Okay, again, I don't deal with it that often, but sometimes it does help. On the other hand, if the patient's debilitated, you can get the scan without IV and you'll get a good scan. Also, a very common situation is the patient's old, they're debilitated, they're having a lot of back pain, And there's a big downside of imaging with IV, and let me explain. It makes the scan take a lot longer. So some of these patients, the indication will be listed as rule out cord compression, and you're going to be scanning the cervical spine, the thoracic spine, and the lumbar spine. And these patients who are in a lot of pain, they might only give you 40 minutes of table time, and you want to get all your pictures as fast as you can, because that patient is going to start moving and squirming around, and then the pictures are going to be of very poor quality when the patient's moving on the table, and the patient will even just say, look, I'm in too much pain, I cannot continue with this scan. So what I'm saying here is it's better to get a decent scan with no IV and be done very quickly than to putz around, give IV, have the patient get pissed off, complain they're in pain, and then stop in the middle of the study, and you can't complete the study. You don't want that. It can be difficult to get the IV in some of these old debilitated patients. So I like my rule out bone mets with no IV, but again, I understand why IV is usually given. For multiple sclerosis, a lot of times I like to give IV on the initial diagnosis, but for the follow-ups, I usually don't need it. Okay, usually it's not going to make much difference, if any, with multiple sclerosis follow-ups when you're imaging, most commonly the cervical spine, but sometimes I'll also image the thoracic spinal cord. Those are the most common issues. If the patient's got a really poor renal function, renal failure with a GFR, glomerular filtration rate less than 30, we'll try not to give it, though we could in an emergency. If they've got a history of an allergy, we'll try not to give it, though we potentially could in an emergency with steroid prep, for example. If they've already got a history of having accumulated gadolinium MRI contrast in their brain and their basal ganglia, deep nuclei, or their cerebellar nuclei like the dentate nucleus with the characteristic T1 hyperintense appearance, then I would also try to not give it to them if I could at all avoid it. And like I said, most of the time it's just back pain and we don't need to give it. So anyways, that's pretty much the scoop overview on when to give or not give IV contrast for MRI of the spine. Hope you found that helpful.